my name's Evelyn. This is my nerve stimulator video. So the first thing I'm going to do is going to set up my machine. So I'm going to go make sure it's plugged into power. And the tank pressure for nitrous is 75, the tank pressure for oxygen is above 1,000, and my pipe pressure is above 50. And then I'll check my interlock system and my gases, make sure those are filled up. And then I can check my nitrous on leak test and then turn on my machine. So while it's turning on, I'll check my screens. And then I'll be able to check my O2 analyzer, and then my scavenging system, and my CO2 absorber. And then I just want to make sure I do a high pressure system leak check. So I'll close the APL valve all the way, pressurize the system until 33 liters of water, and then wait for it to hold for 10 seconds, and then it should pass. And then I can check my valve and my bag machine settings. That should be good. And then I just need to do my room setup. So we're doing elective laparoscopic cholecystectomy on 55-year-old male, 70 kilograms, ASA1B by 24. Some common IV drugs that I'm going to be using is I'll have my midazolam, lidocaine, propofol, rocuronium, SIBO, Zofran, and Spixagamidix to reverse for the case, just in case we finish early or something happens, and I'll have my Apple's drugs. And I also want to have a nerve stimulator to get baseline with muscle twitch, and I'll use trainer 4 in this case to use the force of the twitch. We're going to be doing this after we sedate, though, because this will be painful. And then I'm going to give rock, we'll check the computer, the corrugator to a superciliary eyebrow twitch to measure that I've given enough paralytic and then I can reverse it. So then blades wise, I'm going to give my room, I'm going to give it MAC 3 or 4, and then have a Miller 2 or 3 on standby, and the glide scope, McGrath, fiber optic, difficult airway cart, an LMA, oral airway, and a cry kit and bougies, just because I'm paralyzing, so just in case everything goes bad, I have those as backup. And then I'll have some ETTs, so I'll have an 8.0 tube, half size up, half size down, side-let lube, 22-24 centimeters at the lip, 8 crate foams, an OJ, and suction just for positioning stuff. So then I'll go back and identify my patient, and we're just going to review the chart. So we're going to look at medical history, medications, MH, allergies, and PO status, hypertension, diabetes type 1, if there's any difficult anesthesia in the past, what did they do, any labs, CBC, CMP, and EKG, and they'll do a physical assessment. So I'm going to listen to the heart and lungs, ask if they smoke. I'll do a pre-op, so I'll ask for mouth opening, the 3-3-2, and then chin to chest, and then I'll see if the insides are gapped, see if they have a beard. I'll see their neck thickness, if they're able to jaw thrust, cover or bite their upper lip. So this procedure, I'll be talking about the procedure with them and anesthesia. So we'll be doing a minimally invasive surgery that involves small abdominal incisions and a camera to remove the gallbladder. We'll be putting an ET tube down your throat. Some of the risks are nausea and vomiting, and infection due to surgery and the incisions, a sore throat. Some benefits is that you get the securement of the airway and complete anesthesia, and this prevents the stress response to pain, muscle paralysis to ensure a more accurate surgical precision control. And then and also blood pressure and heart rate are also precisely controlled too. Some indications is that we need complete muscle paralysis because we're inflating your stomach, and we need your lungs to not be super in the way for the surgeon, and we also need you to be holding super still. And then some alternatives is we could do neuroaxial anesthesia, but this center we usually just do general anesthesia. So the consent plan, I'll go over that with them. I'll obtain proper consent and then give midazolam and wheel them back. So then once they're over to the OR table, it'll be really cold. We can scoot the lower, put all the blood pressure EKG stickers on and a warm blanket, and then for this patient, I can ramp if they're super overweight for easy intubation. But then also, we're going to be doing our pre-oxygenation. So I'm just be putting the mask over and gripping the CE technique. Since the patient's an adult, I can just tell them to breathe deeply. But we're going to be denitrogenating and pre-oxygenating for about 5 minutes with 6 to 8 liters of 100% oxygen. And so after that, I'll just tell the patient to breathe deeply. I watch my monitors, and then I'll have my circulator kind of come over when I'm ready, and then I will induce the patient with my fentanyl, lidocaine, and propofol. And once I get all those in, then I can wait until they're in stage 3, and so I can do an eyelid check, and then I can look at their pupils, see how relaxed they are, and make sure they're fully in stage 3. So I will just get so they're in stage 3 right now and fully asleep, and my circulator is standing by for cricoid pressure, but I have my MAC, and then I'll just intubate the patient, making sure not to rock back on their teeth. I can see the cords, and then I approach the cords with the tube, and then ask my circulator for a little bit of pressure, so then I can get the ET through to the cords, and then I take out the stylet and then push it the rest of the way. There we go. So now once I I have that, then I can hook up my circuit and watch for misting in my tube, listen for breath sounds, watch for ETCO2 on the monitor, and then now I will just tape it once I feel confident that's in the right spot. I see chest rise and I don't hear gurgles over the stomach. So now I'm just gonna check my monitors, make sure everything it was successful, and now I can turn on my SIVO and tape their eyelids and just double check that everything's working appropriately. So once that's all done, the case is beginning, and I did push my rock now that they're intubated and comfortable and still out with the SIVO. So now at the end of the case, I need to reverse this because the rock is lasting a little bit longer than the surgeon took, and so I'm gonna use my accelerometer. I'm gonna put the nerve monitoring on with the black negative electrode on the ulnar nerve closest to the hand, with the red one 4 to 5 centimeters behind the black electrode up the body, more closer to the heart. And I'm gonna give a little shock to them, and we should see the adductor pollicis, the thumb, that should adduct like that. And so if that adducts, then that means that they are starting to wear off, and that's good. So my trainer 4 monitoring, my little trainer 4 zapper said it was 0.6 at the adductor pollicis, and so now I have to give Sigamidix because it's not 100%. So I push my 200 milligrams to fully reverse them, and then I do my trainer 4 again, and then now I get a trainer 4 greater than 0.9, so it's pretty strong, 4 twitches, all of them. And so I'm going to do an awake expiration and see a forced exhale and verify that all the twitches sufficiently come back. So now that they're fully awake and I have all my airway reflexes, the patient is following commands, they can lift their head off the table, they can give me 2 thumbs up, they can grip, there's a good tidal volume also on my machine, and they're also spontaneously breathing and kind of coughing now. Now I'll just transfer them to PACU, and I'll have them in high Fowler's position to promote adequate ventilation, and then I'll just pass out the patient information with the PACU nurse. So this is a 70-kilogram male, underwent a lap chole, received 2 milligrams of Versed, paralyzed, and received Sigamidix for reversal. He was fully reversed. I checked his trainer 4, and it was 100% after my second reversal. I also gave dexamethasone and dexmedetomidine and Zofran for nausea and vomiting. Please text me or call me if there's any further questions. Thank you.